Good morning, everybody. So, October is breast cancer month, and it's awareness for us to actually speak to the patients and do complete self-breast examination. But I think an important and underrated part of breast cancer awareness is educating our budding residents and our doctors to understand how to approach a breast lump. So, today I'll be using 20 to 22 minutes to speak about simplifying an approach to breast lumps, right? Okay, so a patient has come to you with a breast lump. What is the goal as clinicians? What is our goal as clinicians, or what is the worry that the patient comes to you with? They're worried if they have cancer or not. So the onus is on us to either prove or refute the fact that they do have cancer. And the idea of this is to assess them clinically, radiologically and pathologically, which has a very high fidelity rate of 99% detection of all breast cancers. This is called triple assessment, and the first part of that is the clinical examination, for which you need to have points in favor of diagnosis and points against diagnosis, for which a structured and an organized approach goes in a long way. Right. So how does the patient present you? Patient will tell you that they have a lump in the breast, or atypically they can present you with nipple discharge or nipple retraction or any skin changes. Sometimes in this day and age, when with the onset of good and robust screening practices, you can have patients who come to you with mammographic abnormalities. Even if that is the case, the first step of clinical evaluation with a good, complete and a thorough history and a complete physical examination cannot be understated. So, when you see a patient with a lump in the breast, I'd like to divide the complaints, and this is something I tell my residents and many of the MBBS classes, so I will sound a little redundant, but there's no harm in repetition, I suppose. So, a patient will come to you with a lump, and you have to identify what the cause is, right? So, the first thing you have to remember is understand everything about the lump. Second thing, you will understand what other possibilities of the lump that you can have, which is also known as differential diagnosis. The third thing is assume that it is malignancy and try to rule out the fact that it is malignancy by asking questions that are pertinent to a malignancy, which we will discuss. So, the patient has come to you with a lump in the breast, right? So, you ask yourself, what else do I need to know about this? So you ask about how it started, how they noticed, how it progressed, how it is right now. Many times patients who are in the late 20s and the early 30s, they have a lot of hormonal changes that happen to their breast tissue. So they will present you with also something called as mastalgia. This mastalgia can present you with lumpy breasts or patients worried about it being malignancy. So if you do examine patients at the time of, during their menstrual cycle when they have heaviness in their breasts and mastalgia, you can always ask them to come back a week later and you can re-examine them to find out if they actually have any lump. Because mammogram, although is not a lot of radiation exposure to the patient, it is something that you need to use very, very appropriately. So, does it vary with menstrual cycle? Is there any pain associated with the lump? Pain is not very commonly associated with malignancy, but yes, some patients do present with a dragging sensation, or they might think that they had pain and thus they have the breast lump, or the other way around. So it's always prudent to ask about history of pain. Always ask about nipple discharge, specifically recent onset spontaneous single duct discharge, that is serous. This is highly suggestive of malignancy, but yes, you need to evaluate the patient for a lump even if they do have a nipple discharge. If they have a lump, we go into the lump protocol. If they do not have a lump, we evaluate according to the nipple discharge protocol, which is a discussion for some other day. Any recent nipple changes, you can ask them if they had any crusting, itching, ulceration, any duct ectasia, or rather any recent onset of ductasia where they have nipple inversion is something that can happen because of underlying ductal carcinoma in situ. So this is everything that you need to know about the lump. Next, differential diagnosis. What else could it be, right? Is there any fever or pain over the lump? Of course, it fits into the clinical picture of a lactating mother who comes to you with fever and pain over the lump with powder-orange over the breast, and then they are worried if it's malignancy. It most likely turns out to be an infective pathology. Chronic breast abscesses can be a problem, right? Any recent rapid increase in size, any sarcomatous changes, any abscess itself can be a recent rapid increase in size. Phylloid tumor is one of the things that you have to consider with recent rapid increase in size. Any swellings elsewhere in the body. Although lipoma is very uncommon in the breast, it is something you can consider because if the patient has history of other swellings in the body. But of course, it also points towards something else which we will be discussing in the next slide. And history of trauma to the affected breast. So, traumatic fat necrosis is something you have to consider in patients because it can present you with a lump and a mammographic abnormality, but it is not very common. Rather, most of the national faculty that I've had whose classes I've attended as a resident and an undergraduate have told that the trauma brings the patient to the notice of the lump, and the lump is not secondary to the trauma itself. So trauma can be just a passenger in the whole disease process, or it could be the reason, but it is always nice to ask in the setting of in the sake of completion, right? Right. Let's just take a small breather. Let's assume that it is cancer, right? When we take your pathology, Robbins, the neoplasia chapter, there are some hallmarks of malignancy. There are 7 points of hallmarks, one of which is its ability to metastasize, right? So when you have any lump that is metastasizing, it is more than likely to be a malignancy. So when you talk about metastasis in anywhere in the body, I'd like to divide it into regional and systemic metastatic disease. Before that, we want to understand if the patient is having locally advanced disease. So at this point, it is very prudent for you to remember the TNM classification, right? TNM classification is something all undergraduates, postgraduates, and anybody who wants to have a breast service needs to know by heart, right? So you have the lump T1, T2, T3, which means the lump exists and there are no other changes. T4 means the patient has skin changes, and there are only three changes that mean it is skin involvement, right? Which means one is one is skin ulceration, satellite nodules, or Powder-Orange. Only these 3 things mean that the skin is involved. Tethering does not mean that the skin is involved. It just means that the mass is growing into the ligaments of Ashley Cooper, and as you're moving it, as you're moving the breast tissue along its arc, the skin gets pulled in, right? So recent onset skin changes is important. That will tell you T4 disease, right? If the lump that initially they felt was mobile, an educated patient will tell you that it is not moving anymore. That will mean that it is fixed to the chest wall or the pectorals, right? So there's a very famous national faculty, Dr. Professor Chintamani, who used to say, easy way to remember is T4A. A means under, so chest wall involvement, and T4B is bahar, skin involvement. So T4A, T4B, T4C is both, and T4D is recent onset swelling of heaviness and swelling and heaviness of the entire breast. This is inflammatory breast carcinoma. There are some criteria. You have to have Powder-Orange of the affected breast for more than 30% of the breast surface, with or without underlying lump, and the patient has pain and heaviness of the breast. And you make the diagnosis with a full thickness skin biopsy where you have plugging of the dermal lymphatics with tumor emboli. Next is regional metastatic disease. Any axillary swellings, patient complaining to you with axillary or armpit lumps, or anywhere else in the body which will denote a metastatic nodule or any other things. And finally, metastatic and constitutional symptoms. Constitutional symptoms is because of cancer cachexia, because of Warburg effect, and metastatic symptoms, the most common site is your dorsolumbar spine. Patient will come to you with low back pain. It can go to your lungs. Patient can have hemoptysis, cough with expectoration, and difficulty in breathing because of pleural effusion. They can have jaundice because of liver involvement, ascites because of the same. They can have peritoneal deposits, and they can have deposits in their cranium or the cerebral parts. So they can have any CNS symptoms as well. So this will complete your history of present illness. When you organize yourself, talk about the lump, talk about the differentials, and talk about the staging from history. Of course, you're going to examine the patient, and of course, you're going to screen the patient with mammogram and do a tissue diagnosis, but you're having a general idea as to what to expect, right? Because a lot of your examination findings can be done away with if you just remember what you need to look for, right? This is important for postgraduates. History of breast biopsies for 2 reasons. This is something that is explained in the Gale model of risk assessment for lifetime risk of breast malignancy, where every breast biopsy increases the relative risk of ductal carcinoma in situ. But in this day and age, where I have told you previously, where patients come to you with mammographic abnormalities, previous breast biopsies can predispose the patient to have mammographic calcifications, which need to be evaluated thoroughly to be ruled out. So, history of breast biopsy should be part of your history of present illness, right? Past history. Now, we're done with the breast complaints itself, but a lot of people have told you from day and age that breast cancer is a systemic disease, right? You need to know if there's any systemic problems for 2 reasons. Number one, to see if the patient has any metastatic or constitutional symptoms, but more importantly, when you want to plan therapy for the patient, you need to understand the patient's comorbid conditions, because in this day and age, mastectomy is something that is reserved for very few candidates. Every woman deserves to have their breast preserved. So breast conservation surgery is the name of the game. It is no longer just an oncological problem, it is also an aesthetic problem. So when you want to plan an aesthetic reconstruction of the breast, it is important, because for completion of your breast conservation therapy, contraindications for radiotherapy will be a relative contraindication for your breast conservation therapy. And there are systemic collagen vascular diseases, any other previous history of radiation toxicities, which will preclude your patient from not completing their breast conservation therapy. So you have to ask of that. Any previous history of surgical interventions, particularly gynecological interventions, radiation exposure, especially to the chest wall. In the past, there used to be radiation for tinea capitis, for lymphoma and all those. Nowadays, it's not really that common, but then again, whenever you have a history of radiation exposure, I'd like to divide it into two categories: therapeutic or accidental. Accidental would mean even people who are radiation workers, people, radiation technologists, radiologists, people who are working in labs like that. And accident or people working in nuclear power plants, right? Therapeutic, yes, very explanatory already. And history of any drug allergies, right? Okay. Personal history, talk about their marital history, their diet and appetite, bowel bladder habits, sleep and adverse social habit. It is important that you do not call it addictions, because addictions have specific definitions. It is important that you call them adverse social habits. Just make a statement of it and move on, right? Family history, a very common statement that all of us say is nil significant. It is never not significant in breast cancer. You have to ask of history of breast cancers or cancer-related deaths in family. This is undergraduate level. When you come to postgraduate level, you're expected to know BRCA1, 2, CDH mutations and PTEN mutations, for which history of breast, ovarian, endometrial, colorectal, pancreatic, gastric or melanomas are important to ask. When the patient gives you a positive history suggestive of a BRCA tumor, and the patient is a young lady with such positive family history, you have to draw a family tree, in the sense a pedigree chart, and you have to go 2 generations up, 2 generations below, and 2 degrees of relatives on the sides. So you have to understand this, and this is the amount of pedigree chart that you have to talk about in family history. Menstrual history is the most important part, because there is a very strong association of hormonal influence in breast cancer. So age at menarche and last menstrual period. For people who don't know this, I did not know this for a long time. The date of LMP is the first day that the lady starts to bleed, right? So just to clarify this, you have to have the LMP, everything about the current cycles, right? How long they bleed, how frequently do they bleed, do they have any dysmenorrhea, do they have any treatments that they need to take for it, and any history of OCPs or hormone replacement therapy in postmenopausal women, obviously not in premenopausal women, right? The reason is you want to identify the risk factor of prolonged and intense exposure of estrogen, because estrogen is a known risk factor to breast carcinoma. Obstetric history is important in the sense, out of everything, you need to ask about any fertility treatments, because patients who have required fertility treatments has a possibility of a hyperestrogenic state around the fertility period itself, and also breastfeeding history, because breastfeeding is a positive factor for protection against breast cancer, which will reduce the risk of breast cancer arising in the future, right? We're coming to examination. Before you examine any patient of any disease, always ensure that you've explained what you're going to do, you've ensured privacy, you have a chaperone if required. Please offer the benefit of a chaperone to the patient who you're examining, and adequate light and exposure. Please do not compromise on that, because there are subtle changes in the breast tissue that you will see only when the shadow falls the right way, right? The general part of it, I don't want to keep going through about it, but when you're talking about built and nourishment, please ensure that you be objective about it. Please measure the BMI, your wards, your OPDs will always have a weighing scale and a height chart. So please measure their BMI. But for all intents and purposes for your exam, most patients that are kept for you are moderately built and nourished. And please look for head to foot examination to look for any signs of systemic disease. Systemic examination, like I said, focused examination to rule out any metastatic symptoms like chest auscultation, cardiac auscultation, and abdominal examination for hepatomegaly and stuff. Although you need to perform this completely when you see the patient in your own clinic, for the exams, sake of the exam purposes, you can keep this abbreviated and make sure that you mention the right things, right? Now, coming to the main part, right? You're going to examine breasts and axilla. So you have to ensure that, again, you're ensuring privacy and consent, you're explaining what is being done, and you're going to undress the patient up to the hip after due explanation of privacy and an explanation, right? So you're inspecting the patient when they are sitting with the hands by the side, arms raised above the head, arms with hips and contracting of the pectoralis major alternately, and leaning forward, right? So this is the classic side position to inspect. When you are inspecting the patient's breast, right, you have to look for number one, symmetry. You have to look whether the nipple level is on the same for both the breasts, because if there is malignancy like we spoke about, there is going to be involvement of your ligaments of Ashley Cooper, which is going to pull the breast up. It is going to reduce your ptosis, right? So that means that can give you a clue as to which side of the breast is involved. Any obvious lumps, some large lumps more than 5-6 centimeters in small breasts, particularly, you'll be able to see the contour abnormality when you're looking at the patient from the front. Skin changes and any NAC abnormalities, nipple areola complex, any crusting, ulcerations, nipple discharge, nipple eversions, duct ectasia, any of these things will be seen on inspection. When the patient is leaning forward, you want to see if both the breasts fall forward up adequately and equally. Again, this is the same explanation. Tethering of the breast tissue to the skin will make the breast fall less forward. This is probably not really required for us in terms of a broader practical purpose, but for exams you need to do this, right? When the patient raises their hands above their head, it will manifest occult tethering, it will manifest occult powder-onge. It will also give you an idea to look at the inframammary region. Patients with a large breast, ptotic breasts, they have the chance of having intertrigo, which you need to treat before you plan any mastectomy or any type of treatments, right? Pectoralis major contraction. So when you contract a muscle on top of which there is a lump, it will get pushed outward. That is the basic physiology, basic concept behind asking anybody to contract. So you ask them to put the hands on the hip and ask them to contract. But how do you know if they're contracting, right? So you need to palpate the anterior axillary fold to make sure that the pectoralis major is taut, so that you can confirm that they're actually doing what you're expecting them to do and see if there's any lumps, right? Okay, now coming to palpation, right? This image is from Browse's Introduction to Signs and Symptoms in Clinical Surgery. You have to measure the breast size and the cup size. This is important in current day and age with mastology, where you're planning for breast conservation surgery. You measure in inches across the nipple level and the underwire under the breast, and then subtract that and you will get the cup size. This has to be done because if you're planning any form of reconstructions, even if you're performing a mastectomy, if you want to reconstruct, you need the patient to have an aesthetically pleasing looking breast. Like I said, it is no longer just an oncological concern, it is also an aesthetic concern, and every woman deserves to have their breasts conserved, right? So you have to ensure that you do this. Undergraduates probably don't need to do this, but postgraduates are expected to do this, especially when you're presenting in any national forums. Warmth and tenderness always, and please palpate the normal breast first, right? You have to look at both breasts and palpate the normal breast first. Use the flat of your hand to palpate. Ideally to be done when the patient is semi-recumbent or lying down, but you can do it when the patient is sitting. Because when you're pushing with the flat of the hand, you don't want the patient to fall back, right? Common sense. So you support the patient in the back and do it, or lie them down. Confirm the site, number, size, consistency, mobility and fixity of the swellings. Palpate the nipple areola complex for any discharges or any occult lumps. Right. Palpation of the axilla is something that you can expect your examiner to ask you to demonstrate. So you see that yellow, I don't know if you can see it right there, there's the axillary crease, right? The yellow arrow is pointing at the axillary crease. If you put the tip of your fingers at the axillary crease, and then you ask the patient to drop their hand on your examining hand. Use your right hand for the right axilla and the left hand for your left axilla. If the patient drops their hand, this will relax the axillary fascia. When the axillary fascia is relaxed, you're able to palpate the entire axillary group of lymph nodes comfortably. So for your medial group, apical group and central group and your anterior group, you have to palpate this from this position, and when you have to do the posterior group, you have to go behind, make sure your patient moves their hand to the other side, again limp, and then you're holding and palpating the posterior and the lateral groups, right? So during my residency, I was taught breast case examination by my professor, Dr. D.K. Sharkar, and he used to tell us the 10-point checklist. This is a practical tip so that you don't forget anything about your breast examination. So it goes lower inner, outer, lower inner, lower upper, upper outer, upper, lower outer quadrant, NAC, that makes 5. Axillary tail of Spence and axilla, that makes 7. Supraclavicular fossa, which you have to do it when you're doing the posterior group examination, that makes 8. Upper limb of the ipsilateral side makes it 9, and number 10 would be the opposite breast and axilla. If you remember this, you are not going to forget, because patients nowadays are presenting to you in a younger age group where they have a chance of having BRCA mutations or possibility of multicentricity, which means that the opposite breast can also be involved. So you have to ensure that you treat them appropriately. Always do not forget to examine the spine and skeletal systems. There can be occult spine metastasis, or there can be patients with tenderness which will need evaluation. Digital rectal examination and pelvic examinations are indicated in patients with advanced disease. Do not put patients through this unnecessary burden of having to do these examinations if you think the patient has only an early breast carcinoma, right? Okay, summarizing. The history has to be summarized. Remember, imagine you are reporting about this case to some super consultant, and you have to report to them between 2 floors on an elevator, right? So that's what I call the elevator pitch. So when you're doing the elevator pitch, please remember only the salient points. Basic patient particulars, menstrual status, comorbid illnesses and adverse social habits, complaints and progression of the disease with relevant hormonal and familial histories has to be part of your summary, and salient examination findings. If you remember this, your summary writing will be easy, but then again, it's a question of practice. So please make sure that you write mock case sheets and practice case presentations so that you don't miss anything and you're summarizing. And these summaries are important when you're doing your morning rounds with your consultants when you see breast patients in the ward, right? So your diagnosis, because this is a breast CME, we're going to talk about carcinoma breast only. It will be carcinoma breast of the site with TNM classification, which I said everybody needs to know. Although yes, in AJCC 8, the TNM staging depends on the ERPR and HER2 status. Clinical staging is still recommended that you do from all undergraduates and postgraduates, right? So summarize. First thing, history, talk about the complaints, the lump, any pain or tenderness, nipple discharge, gynecological and familial history, right? This is from Hamilton Bailey. The second one is from Browse's Introduction to Clinical Science and Surgery, where for the examination, look at the size, symmetry, everything about the skin, nipples and areola, axilla and the arm. Please do not forget to feel the normal breast first, examine the axilla and the arms, examine the supraclavicular fossa and look for systemic signs of malignancy. And finally, this is the universal notation for any breast lumps. Please ensure that you draw this on your case sheet so that everybody knows what we're dealing with, right? Right, so if you can scan this QR code, there is a model case sheet of breast carcinoma that I've made specifically for this presentation. That is for you. A postgraduate is expected to present this, a breast case in the format that I have typed in this way. But if you have any other questions, you can please ask me, and that will be the end of the session. Thank you.